Today, we will be speaking about the pediatric COVID-19 vaccines with Dr. Jacqueline Wong. Dr. Jacqueline Wong completed her Bachelor of Science in Pharmacy and medical degrees at the University of Toronto. She then completed her pediatric residency at BC Children's Hospital in June of 2014. Dr. Wong is a staff physician and assistant professor in the Department of Pediatrics, Division of Infectious Diseases at McMaster University. She completed an advanced clinical fellowship in antimicrobial stewardship at the Hospital for Sick Children in 2017. She has also completed a master's degree in health research methodology at McMaster University. Hello and welcome to Friendly Pharmacy 5. My name is Lindsay Dixon. I'm a pharmacist from British Columbia, Canada. And today we will be speaking about the pediatric COVID-19 vaccines with a very special guest. We have Dr. Jacqueline Wong here today. Dr. Wong, thank you so much for joining us and sharing your expertise with us.
Oh, it's a pleasure. Thanks for reaching out to me.
You know, parents have been through so much during this pandemic. I mean, everyone has, but parents, I think, have felt a special crunch kind of during this whole pandemic. And now we're faced with this decision of vaccinating our children with what we feel is a fairly new vaccine. And there are a lot of questions about the vaccine. And I'd like to let viewers know that the questions that we're going over with Dr. Wong have actually been submitted to me by viewers. So these have been submitted from different social media sites from parents who are in this place of trying to make a decision of whether to vaccinate their children for COVID-19. So Dr. Wong, one of the biggest questions that comes up right away is, we had this understanding, or a lot of us had the understanding, that COVID-19 was usually a more mild illness in children. And if it's so mild, and if we haven't really seen severe cases maybe in the region we live in, why should we be considering vaccinating children for this? Is it really necessary?
Yeah, that's a great question. And it always comes down to what are the benefits of doing something when we're talking about kids, especially when we're talking about vaccines, which are given to people who are otherwise healthy. So like you said, definitely a COVID infection and this pandemic from a acute health perspective, thankfully has been very mild for children. The vast majority of them have very mild symptoms, and some of them don't have any symptoms at all. And it's, the infection is picked up because of contact tracing that needs to happen. But there are, a minority of kids that do end up needing to be hospitalized, who do end up needing ventilatory support in an ICU. And there are a handful of deaths that we've recorded in the country. So severe outcomes do happen. The other thing is, children can sometimes experience this inflammatory syndrome. It's called MISC here. They call it PIMS across the pond, but it's a multi-system inflammatory syndrome that we see in children, and it can happen after a COVID infection. And it's not dependent on how mild or severe the infection is. And when we're looking at those MISC cases, yes, more of them end up needing to be hospitalized because they're sicker, they have longer periods of fever. So that's kind of the symptoms. I guess I should also mention too, there's the concern about lingering symptoms after someone has gotten better from COVID. And some people call it long COVID. Some people will call it, other non-specific symptoms following a viral illness. Now, this isn't new to COVID as a respiratory illness. We see this with kids who recover from the flu, for example, or teenagers and adults who recover from mono, like where you're kind of wiped out and off your feet for sometimes up to 6 weeks. So these kind of post-infectious symptoms aren't new. So then going back to your question about why would someone want to consider a vaccine? Vaccines provide predictable, reliable protection against an infection without needing to go through the symptoms of the natural infection, right? Because you don't know if your child will be the vast majority who have a very mild course, or they might get very sick. So this is a safer and more reliable way to get protection from the COVID-19 infection. So that's one way of looking at it. If you prevent infection in a child, then you're going to prevent those cases of inflammatory syndromes, and potentially, the prolonged symptoms after the acute infection. We would expect all of those things to be less frequent if kids aren't getting COVID. I think the other thing that families have to consider are their unique circumstances, like who lives with their child, who helps look after their child. Maybe it's an elderly grandparent, maybe it's someone who's not eligible to get the vaccine. So by preventing an infection in your child, you prevent the risk of that infection being transmitted. I mean, the vaccine was just licensed for, wider use. So this is, I guess, in a sense, theoretical, but it makes biological sense that if your child is protected from an infection, there's less likelihood they're going to come home sick with it, and less likely they'll give it to someone else in the household. What we've seen as well in adults, those who have breakthrough infections when they get, after being vaccinated, they tend to be contagious for shorter periods of time too. So that's reassuring for families. And then, lastly, the livelihood of kids has been so disrupted for the last almost 2 years, right?
Mm-hmm.
Interruptions and cancellations to school and extracurriculars, depending on which part of the country you live in, depending on which country you live in. And so having this vaccine available, and for a lot of families who are ready to take it up and to send their kids to get the vaccination, by having fewer cases in schools and in other extracurricular activities, it means you don't have to interrupt things so often. It means that you don't have to quarantine every single time or dismiss the class for as long a period, or you don't have to dismiss the whole entire class every single time. So there are, I guess I'll call these kind of indirect benefits to having your child protected from COVID, in addition to avoiding the symptoms in your child themselves.
Mm-hmm. Thank you, Dr. Wong. That's a very comprehensive answer for us. And there are a lot of different factors, I think, that we really do need to look at. So could you tell us, these vaccines, so these mRNA vaccines, I know that they've been researched for decades, but these are new to us as a population. And could you explain how these vaccines work to generate immunity? And maybe is that process at all different when we're talking about children?
Yeah, so we don't expect the process of how it generates immunity to be any different in kids versus adults, based on the age or based on the weight of the child. The principles are still the same. How robust someone's immune system is definitely varies over the course of their lifetime. But the principle behind the mRNA vaccine is when you get injected with this very small amount of messenger RNA, that's what the M stands for, it's like a set of instructions. So whichever cells take up these instructions, they'll read the instructions and they'll figure out their machinery to make spike protein. The spike protein is then, released from these cells, and your immune system will say, hey, this spike protein doesn't normally belong here. This body doesn't normally make it. And so it will make antibodies against that spike protein. And so some of those antibodies are meant to remove the spike protein then and there. Some of these cells will then become memory cells, meaning they've got a library of foreign proteins, invaders, things like that, the next time they encounter it, they can make antibodies against it. So that's how this vaccine generates that response. The vaccine is intended to safely mimic a natural infection. So when you get infected with COVID-19, you're exposed to not just the spike protein, you're exposed to other proteins on the cell, on the virus. And so, yes, your immune system will make antibodies directed at other parts of the virus. Now, not all of these antibodies will help remove the virus out of your body. They might not help prevent the virus from invading or entering cells. So, one of the common things I've heard is, well, isn't natural immunity better because you make a greater variety of antibodies? That's kind of like plus minus, not necessarily.
Okay.
The other thing is when you're exposed to the virus, you can, like, I could get exposed to a big amount, or I could get exposed to a little amount, as opposed to a vaccine where you're getting the same amount of coding instruction every single time. And that goes back to the point about being more reliable in terms of the immunity that it produces. And because the mRNA is not a live vaccine, you're not going to get sick with COVID-19. You're not going to get the symptoms, for example, like cough, and you're not going to be able to spread it to someone else. So there are other, I guess, advantages to developing immunity following a vaccine as opposed to getting the natural infection.
And another question that came up was, are these actually vaccines, or is this a type of gene therapy? This was the question. Could you speak to that, please?
Yeah, for sure. So these mRNA-derived vaccines are definitely not gene therapy. They do not get incorporated into your body's DNA. They don't permanently, tell your body to keep generating spike proteins and upon spike proteins. So the mRNA gets taken up by your cells very quickly. Anything that's not taken up by the cells is broken down by your immune system and your other organs. It's broken down within a few days. So it's not something that can perpetually exist in your body. It doesn't get incorporated into your DNA. As I said, part of your cell's machinery just reads this instruction code. We don't have the enzymes. One, this mRNA was not designed that way. Two, we don't have the enzymes to actually translate it into DNA and then incorporate it into our own DNA. And then lastly, once your whatever cells have taken up the mRNA and they've used up that coding and they've made the spike protein, that's it. That mRNA doesn't live infinitely in your body.
Mm-hmm.
Whatever spike proteins have been made, they've been made. They trigger an immune response. And as a result of that immune response, they're removed from your body in a matter of weeks. I'd probably say within a month or two. So definitely not gene therapy, definitely a vaccine.
Mm-hmm. And I think it's also important to point out that the spike protein that is generated from the mRNA in the vaccine is not completely identical to the spike protein from the virus. So it cannot attach itself to cells or cause toxicity or anything like that. Is that correct?
Yeah, that's right. That's right. It's not exactly the same. They focused on the portion of the spike protein that will invade into cells, because that's what you want your antibodies to block.
Right.
And this spike protein is just a fragment of the virus. So that's why, it can't replicate in your body the same way getting sick with the virus would. Mm-hmm. And you can't spread it to anyone else. So the spike protein is not shed from your nose, your throat, when you're coughing, your secretions. It's not shed at all, and it wouldn't be spread to other people that way.
Mm-hmm. That's great, Dr. Wong. If we can shift a little bit to talk about the clinical trials and how the pediatric vaccine is different from the adult vaccine. First of all, I know that there's a difference in dose and a bit of something in the formulation. Right. What are the differences in that? Right.
So the mRNA, the active ingredient, it's the same one. They didn't update it, but you're right, the dose is different. So the adult dose is 30 micrograms. The pediatric dose is 10 micrograms. And to your second point, the other fillers or buffers in the vaccine have been slightly modified. So they use slightly different salts. And this basically resulted in a product that was much more stable, much easier to transport, much easier to store. Because if you guys remember from the beginning of the vaccine rollout, there were big challenges about how do we keep this vaccine at -80 and trying to find these industrial freezers, and how long can it be put in the refrigerator for, which is relevant when you're talking about a big rollout, right? At these vaccine centers. So for example, the pediatric formulation is stable in a regular fridge for 10 weeks, which is huge.
Yeah.
In terms of mobilizing the product to different places where vaccinations can happen, places that don't have industrial freezers. The other thing is the vial looks different. So the adult product has a purple cap. The pediatric one has an orange cap. So there are visual cues there to help providers avoid erroneously giving the wrong product. So for those differences, especially the buffer, and I should say that the final volume that goes into the arm in an adult is 0.3 mLs, and in children it's 0.2. Okay. So for those reasons, you can't just take an adult vial and like split the dose into 3 portions and give it to children. There are some subtle differences.
And how many kids has this been tested in the clinical trials? Do you recall?
Yeah, so the clinical trial that was published in the New England Journal of Medicine had, I think it was about 1,500 and change in terms of kids that got the vaccine, and then 750 who got the placebo. When you look at the Health Canada website, they actually received more data from an additional second cohort that was really, this cohort was really focused on just kind of safety monitoring. Okay. So in total, we have about 3,000 odd kids who got the vaccine in a controlled setting in a clinical trial. Versus like real life, like at the time when the vaccines were licensed in Canada, they were already licensed in the States, and there were already like 2 million plus doses already administered there. So we have information from its use in controlled settings, and then we have information about its use from kind of real world settings.
Yeah, I actually, just before this interview, I was looking online, and I think it's over 5 million children now in the US have received one, and some have started have had their second dose too, because they are doing the, I think, three-week interval.
That's right.
Down there. And do you know how effective these vaccines are against the variants? Because we live in a world where we're hearing about new variants all the time. I guess the one that's predominant right now in Canada is Delta still. Yep. Are these going to be effective?
Yeah, we expect them to be. So I think I will try to answer that question from the adult perspective. So, you know, especially for those of your viewers who are very active on Twitter, for example, a lot of other scientists and healthcare providers have been trying to provide summaries. So there's lots of studies going on. These are observational studies, meaning looking at real world use of how well the vaccine is protecting people right now amidst, you know, the circulating Delta variant. And so from study to study, you'll have slight variations in numbers. Yes, there is slightly less protection against the Delta variant than the original variant, meaning, yes, we're seeing breakthrough cases. So people who've had 2 doses, presumably normal immune systems, and they are still getting symptoms and infected with COVID and the Delta variant. But what we're seeing is that these breakthrough infections are mild. What we're seeing is that they're contagious for a shorter period of time. What we're seeing is, compared to those who are not vaccinated, these people are fortunately not ending up in hospital, not ending up in ICU, and thankfully not dying at the same rates as someone who's not vaccinated. So what that means is, even though the vaccine might not protect against all symptomatic infections as well as it did in the original studies with, you know, the wild type back then, it still offers very good protection against severe COVID. So I would expect all that data is going to extrapolate to the pediatric population, though, you know, for some people maybe a little bit less relevant, because thankfully kids don't end up in hospital quite as often. The other way I would answer or approach this question, in the trials looking at the COVID vaccine for children, they also wanted to know how many kids got the infection. So when they ran their statistics, it offered an efficacy of 90.7%, regardless of whether you were previously infected with SARS-CoV-2 or not. Meaning that, by getting the vaccine, like you're going to have a 90% less rate of symptomatic infection. And now the study authors didn't provide sequencing data for those positive cases, meaning at this time, we don't know for sure if they were Delta variant or not, but the timeline of those studies and when these infections occurred, we assume the majority of them were Delta variant because that's what's circulating, especially in the US and a few of the other countries that were where patients were recruited from the EU. The Delta variant is the predominant strain. So I would be comfortable saying that 90.7% efficacy would apply to our current situation.
Mm-hmm. That's excellent. Yeah. And that's even higher than what we're seeing in adults right now. Like, I think I saw one of maybe it was Moderna, which is not what we're doing for pediatric vaccines right now in Canada. I think that was about 88% effective. So a 90.7 or something percent efficacy rate for children is very good.
Yeah, it's very reassuring. And I mean, there are limitations, right? Like the trial wasn't as big as the adult trials. So, during that time frame, none of the kids ended up with severe infection needing hospitalization. Now, these trials are still ongoing. So it's hard to, provide an exact timeline, like in terms of what was reported or what was submitted to Health Canada. The trials were enrolling their phase 2-3 portion in June, and then we had data up until October that was submitted to Health Canada, but they're still ongoing. So they're going to continue to capture events like the number of symptomatic cases, the number that require hospitalization. And thankfully, they didn't see any major side effects like anaphylaxis. They didn't see any myocarditis either.
Yeah, and that's
numbers are small.
Yeah, and that's also very reassuring, though. What would be some side effects that would be normal that parents would be watching for in their kids?
Yeah, totally. So, like other vaccines, local site infections were definitely reported in the study. So this would be like redness, soreness, maybe a little bit of swelling in the area. They were also paying close attention to fevers, headaches, muscle achiness, and swollen lymph nodes that you can sometimes get.
I was going to ask you about that.
Yeah. So the local reactions like the redness, soreness, and a little bit of swelling, they saw that in a lot of the kids, but it was mild, lasted no more than a day or two. The more systemic side effects like fever, headache, myalgias, and the lymph node swelling, there was less of that in this younger population than there was in the 16 to 25-year-olds, presumably because we're dealing with a smaller dose. So, in actuality, you have a smaller dose that's able to generate similar immune response, very good efficacy, and is better tolerated. And that was like the very first part of the trials. They were deciding whether they should use the 30 micrograms that adults got. They found that there was way too much local reactions, or the severity is kind of, I don't know if intolerable is the right word, but it would make it very unpalatable for people to want to assign their kids up to get this vaccine. So then that's how they decided, okay, going forward, we're going to use the 10 microgram dose.
And I think also it's important to discuss the fact that these vaccines are dosed by age, not by weight. Because when we think of children, you can have an 8-year-old who is just huge, and then you can have an 8-year-old who's also like 30 pounds lighter. So why is this that there's no concern with weight? We just look at age generally in when it comes to pediatric vaccination.
Yeah, like you said, like all of our other pediatric vaccinations are not based on weight.
That's right.
They're based on age.
Yeah.
They're based on age brackets. And so it has to do with how your immune system matures and changes over time rather than how much body mass that you have. And so like a common question that I got from parents was, my child is 11. Should I wait for them to turn 12 to get the bigger dose? And I would say there's really no advantage to waiting. What we saw from the data in the trials is when they used the 10 microgram dose for the kids under the age of 12, the amount of antibody response was the same as using the larger 30 microgram dose in the older kids.
Oh, okay.
So I would say there's no advantage to waiting for the bigger dose. It really comes down to, when families and their children are ready.
Yeah. That's a good point, because I've heard that question as well about the 11 versus 12. So thank you for pointing that out. What about myocarditis, Dr. Wong? This has been a big topic. I know that myocarditis is more common in younger men, though we have seen it in some women. How does this play out? How is this expected to play out in the pediatric population? I know it's early days, but how have you seen it? Did it even come up in the clinical trials? I think you just said there was no myocarditis.
They didn't see it. See it. So, again, for the viewers out there who might not have heard so much about this myocarditis association. So before the rollout of the vaccinations in teenagers, like we knew that myocarditis can sometimes follow acute COVID as a complication.
Okay.
Not at the time of acute COVID, but following acute COVID. And the rates of myocarditis following a natural infection are higher than they are associated with a vaccine. And I'll defer the conversation about the adverse event monitoring systems that we have in place in the US and in Canada that actually work to detect these associations, right? And they look through the data that a clinician would submit in to see if this is a true association or not. So we'll put that aside. But yes, we saw that in kids, especially teenagers and young adults, we were seeing this association with myocarditis more than we would have expected if they didn't get the vaccine. What we kind of have learned from that experience is we see it, as I said, more in the teenagers and young adults in terms of being vaccine related as opposed to older populations, probably because their immune system is more robust.
Yeah.
We see it more often in males than females. We see it more often after the second dose, usually within a few days of that second dose. And we see it more often when the vaccine is given, the two doses are given close together. So when we kind of look at the experience in, let's say, Israel, where they really stuck to that 3-week interval compared to other places, for example, here in Canada, where we were more lenient with the interval for different reasons. So in terms of what we know about vaccine-associated myocarditis in the teenagers and young adults, it tends to be mild. So people are really vigilant and looking out for it now. So if someone has chest pain, shortness of breath, they're feeling dizzy or faint, these will usually, and then they also got the vaccine recently, they tell an emergency room physician this, their regular doctor this, people are on heightened alert to say, you need to go to a hospital to get checked out. And out of precaution, of course, we admit someone who has myocarditis to follow their lab work, to observe them and make sure that they're safe. But thankfully, these kids go home after 1 or a few days. The inflammatory markers that we use to kind of diagnose myocarditis, those are normalized before they go. And we will look at their heart muscle function during their admission as well. And thankfully, the vast majority of them, almost all of them, have no problem with their heart function. So from an immediate perspective, thankfully, it's mild, it's short-lived, kids go home not having required any special treatment or interventions or anything like that. What remains to be determined, obviously, what is the long-term effect of this, right? Like, these kids are obviously going to be followed by heart specialists for the long run to see, even though everything is resolved now, is there any sort of long-term deleterious effect on heart function? As I said, we see this, this myocarditis, pericarditis more in someone who's had a vaccine versus not had a vaccine. But we still see it even more in people who've had COVID-19 infection. So again, putting it all in context is important.
And just to clarify, myocarditis is, and I should have asked this first, but my understanding is this is an inflammation of the heart muscle. Someone did comment to me saying it means there's dead heart muscle, but that's not true. It's an inflammation, and the heart can recover from this.
That's right.
Is that correct?
That's right. That's right. So it is an inflammation. Thankfully, it's temporary. And the reason why we know it's not death of heart tissue or ischemia, again, the tests that are run in hospitals, like the echocardiograms and the ultrasounds that are done of the heart that look at function, they look at, is the entire heart muscle moving appropriately? Are there spots that aren't moving that would suggest ischemia? So we are looking out for those things, but myocarditis by definition just means inflammation.
Okay, that's great. Thanks for the clarification on that. And other than those side effects that we've discussed, as a pediatrician, do you worry about long-term side effects with these vaccines in children?
From a theoretical perspective, I don't. And a lot of that goes back to, the components in the vaccine. So the mRNA doesn't last in our circulation beyond a few days. The spike protein that it programs, or rather instructs your cells to make, doesn't last for longer than a few weeks. And then you have the other components, the buffers, the salts. Those are used in other vaccines that we have many decades of experience with. And we thankfully don't see long-term side effects from it. But, as a parent myself, right, and as a pediatrician, this question will, be on people's minds. And that's why we need the monitoring systems that we have in place here in Canada and the US, so that, and also the drug companies are expected to follow their patients for a certain amount of time after getting these vaccines, so that, if we're starting to see some sort of signal that we're having more of some unpredicted or rare side effect, that we can catch it once, many millions of doses have been given out. The trials aren't designed to look for rare or very, very long-term side effects. It is one of the limitations of these trials. But, kind of extrapolating from our experiences with what we know about mRNA, we know about these other vaccine components, the buffers, the salts and stuff, and also like previous experience with mRNA vaccines, as you alluded to, for a lot of the population, mRNA vaccine seems like this brand new technology, but it's actually been studied for other things as well. For example, like Ebola and HIV and rabies, for example. And I was reading about kind of the history of it, and the use of mRNA-based vaccines, or trials of it anyway, can have dated back over a decade. I think 2006 was one of the earlier trials that I read about. So we do have some, not tons, but we still have some longer term data from those other experiences that, help reassure me when I'm giving this information to patients that I meet.
Yeah, no, that's really important. And these vaccines for children, my understanding is that the series is 2 doses, but now we are seeing that some adults are being recommended to take a 3rd dose. Do you expect that in children, or do you have any kind of insight as to how this could go?
Yeah, so the 3rd dose is for adults. I think the way that most people are familiar with it is in the form of a booster dose. So in an otherwise healthy person who's gotten 2 doses and, may have waning or decreasing antibody levels, which is our only surrogate marker for protection right now, that there are recommendations to get a 3rd dose if you've been beyond 6 months. In that respect, probably the conversation about 3rd doses is going to come to children. It's just a matter of time when we learn, how long these antibodies last in children. But, as a population or a subgroup of the population, children in this age group have a more robust immune system than, let's say, a 65-year-old. So I would expect their antibodies to last or be detectable longer than what we're seeing in older adults. And who knows, given time, maybe there will be a different assay to look for immunity. Because if you remember, I said, we can look at the amount of circulating antibodies, but there's also these memory cells that make antibodies when they're exposed to an infection in the future. So we don't measure memory cells, but maybe there will be an assay that comes out that looks at that a little bit later. That's a more dynamic measurement of our immunity against COVID. So with different assays, maybe how that question is answered in kids, 3rd dose eventually, probably, I just don't know when. And there's also all these variants that are going to unfortunately keep cropping up if, because this is a global pandemic that we're still working to get under control. So with evolution of different variants, there might need to be modifications to the vaccines. And that might be a reason why boosters come along. Again, probably the smaller subset of the adult population that gets 3 doses, for those who have immunocompromising conditions, specifically like those who've had solid organ transplants, those who are getting chemotherapy, those who are on certain medicines that like weaken your immune system's ability to make antibodies, those people after 2 doses don't get a good antibody response. So those people actually get 3 doses. So their primary series is 3 doses. So again, it sounds very semantic, but that 3rd dose would be considered completing your primary series rather than a booster. That philosophy is going to apply to the younger children, like the 5 to 11-year-olds too. It's just a matter of when. Of timing. Just a matter of, timing. Because from the original trials, they did not include children who were severely immunocompromised, either like an underlying condition or because of a treatment they were getting. They were not in that initial Pfizer-BioNTech trial.
Okay, that's good. That's good to know. As parents, we can just kind of have a heads up that there could be a 3rd dose. I mean, there are 3 doses of other vaccines for children, right? That wouldn't be anything too surprising, but it's good to know that might be on the horizon. Just a question I wanted to ask you about parents who like pregnant mothers, so people who might be becoming parents and are thinking about this vaccine. I know you're a mother yourself. What do you tell your patients about if they're pregnant and they're considering whether it's safe to get the vaccine and whether it's needed?
Yeah. So for, patients of mine or family or friends of mine that are pregnant, I have no trouble saying these vaccines are safe for use in pregnancy. Again, the way that that wording came out initially was a little bit bumpy.
It was,
because the initial trials didn't include pregnant women, and that's normal. I'm not saying I agree with it, but that's the standard for a lot of these clinical trials, where they don't want to incur that additional risk as a pharmaceutical company, so they exclude women who are pregnant. But of course, sometimes people don't know that they're pregnant when they're enrolled in these trials.
Right.
And so there were some, surprise pregnancies at that time. And there were people who got pregnant shortly after getting their vaccines as well. So from that small body of data, we saw that the number of spontaneous pregnancies in those who got the vaccine versus didn't get the vaccine same. The number of complications like miscarriages, the same. And then we expanded the use, and then we have more real world experience. And so again, we're seeing fertility rates no different between those who get the vaccine versus, age controlled, similar populations. We are thankfully not seeing any difference in rates in miscarriages or major malformations during the course of the pregnancy, if you've received this vaccine versus if you didn't, or like compared to, like, let's say a historical population when this vaccine didn't exist.
Right.
So that's, always reassuring and adds kind of confidence to us being able to say that this is safe. But, going back to decisions come down to what are the risks and what are the benefits, right? Like, generally pregnant women are younger and they're healthier. So as a subgroup of the population, they don't have as much complications from COVID-19 as the subpopulation that's like 65 plus, let's say, right? But when you look at pregnant women and you look at those that get COVID-19 during their pregnancy or shortly after they've delivered, and you compare it to other women in that age group, no medical comorbidities, but aren't pregnant, there's a higher risk of hospitalization with COVID. There's a higher risk of needing intensive unit care if you get COVID during your pregnancy. So there is benefit to be had from getting this vaccine during the pregnancy to try to prevent those more severe outcomes.
Mm-hmm. Well, thank you for that. I know that that's still a question that's out there, and as mothers, when we're pregnant, we want to do the best thing for our babies and for our own health. And so it's something that I know has been on the mind of a lot of people. So thank you for clarifying that for us. I'm almost through all of our questions. I've made you talk quite a bit. Just in closing, for parents who maybe are still unsure, and we're heading into Christmas break, do you have any suggestions for, some kids who are still not vaccinated? Kids in Canada will only have one dose if they've had any, and we're heading into a season of a lot of gatherings and that kind of thing. Any advice for us?
Yeah, for sure. I think, for families where their kids have had one dose still offers protection above and beyond no doses, right? And I recognize that, a lot of families were really disappointed with the timing of the approval and the recommendation that we spread the doses apart a little bit further. But again, after one dose, there is an antibody response. It's just not as sustained. And that's why we give a second dose. And I think it's great that NACI looked at our Canadian experience and found that, by increasing that interval to 8 weeks, you actually get a better, like a more robust, a more sustained antibody response, if that's your end goal, right?
Yes.
After the 2 doses, and you're trying to limit those side effects. So, trying to, again, put it in perspective for families. But things that we knew before the vaccine came about still work. So, you're trying to decrease the number of contact points with someone who might have encountered this infection. So generally that means smaller gatherings or spaces where you can keep your distance from other people, especially over the holidays. There tends to be a lot of eating and beverage consumption at these gatherings, right? So you're just trying to increase the space between people so that when people have their masks off and they're eating and talking, there's less likelihood that if someone is, infected with the virus, that it can spread to other people. Or choosing activities that are outdoor based. So, since we're talking about kids, skating, skiing, all those outdoor activities, speaking from living here in Toronto, the the restrictions, the number of people that could participate in these outdoor activities, those were lifted this year. So, yeah, because last year you had to sign up and there were times and all this stuff. So it's a lot less restricted, meaning easier for people to get outdoors, to spend quality time with people. You're trying to spend time with people that either live in the same household as you, or well, so you understand how, like, what their exposure risk might be.
Right.
So that's, again, trying to decrease the number of contact points. But there are circumstances where you might not be able to. And so we know that masks work. This is, continues to be controversial in many different funny ways. But, if we leave the specifics about the type of mask, et cetera, but if, going for something that fits well, that has multiple layers, and when it comes to kids, like, it needs to be comfortable. So you're looking for something that's going to be probably cotton, something, rather than rigid. Like, if it's not comfortable, they're not going to wear it. And then, then it definitely doesn't fit. Making sure kids know how to wear it, like, it's got to cover your nose and your mouth, and in order to kind of actually protect you and protect people around you. And then for any cough and cold season, hand hygiene. So making sure that you're washing your hands frequently, or using that alcohol-based wash that, like, everyone carries on their knapsack and their purse now, especially before you touch your face, before you eat, when you come in from, running errands. Like, these are things that, we knew through different respiratory illness seasons. These are things that these are tools that we've had in our toolkit since the beginning. And it's just about different layers of protection. So parents are still well equipped, even if they haven't had 2 doses of vaccines for their kids, even if they're not, their kids aren't old enough to get it yet, parents are still well equipped to help protect their kids. And with rising rates of vaccination in the community, like, that's indirect protection for the kids too. So there's a lot to be, I guess, positive about heading into this holiday season.
That's great. I mean, it's good to be mindful of these things, that we are still in a pandemic, but we do know a lot more now than we did before. And I really appreciate the reminder about hand hygiene, because I know as a parent that can kind of fall off sometimes. I mean, we get so focused on different things like the mask and the vaccine, but these simple things, like you said, these are historically proven to work, and they work for COVID too, right? Yes. So I think that's a really good reminder to be vigilant about these things and do what you can, limit your contacts, or just be mindful of these activities that you can do safely.
There's no, like, and one of your earlier questions was, what do I say to families, we're having these conversations about the vaccine, and there are a lot of from a scientific perspective, a lot of evidence to let us know that these vaccines are safe, that they work. There are obviously limitations to what we know so far. Each family has a unique circumstance. The things to be gained from vaccinating will vary from household to household. And so I think it's important that families have access to, be it a pediatrician, a family doctor, a primary care provider, specialist, if your child has additional medical needs, who understands your unique circumstance and what this information might mean for you. And to your original question right at the beginning about, why do we need to have our kids vaccinated if this disease is relatively mild for most kids? Absolutely. Like, there is no immediate rush. Like, I think that's important for me when I meet families, is there's no rush to get kids vaccinated. What's more important is that parents have access to reliable, medically correct information, and platforms like this are huge, are so valuable. And the parents need to feel comfortable and confident in the decisions that they make. And like so many other things in parenting, your opinions about things change with time. Sometimes circumstances change. And so, and we'll learn more about COVID. We'll learn more about these vaccines. And so having an open door to, revisiting this conversation, I think is probably more important than rushing a family into a decision if they're not ready yet.
And that's really important. And I appreciate you saying that, because even as a pharmacist, I have patients who have had issues with other vaccines. They have been hesitant about getting a vaccine for shingles or something like that. And it's about making an informed decision. We talk about informed consent. It's not about pressuring anyone. And there is a lot of pressure out there. Everyone's under a lot of stress, and everyone's asking, are you going to get the vaccine for your kid? Are you not? Why? And I think it's important to take a step back and look at good, reliable sources of information, look at your family situation, and make a decision for you and your family. And I really appreciate you saying that, because it means a lot coming from a pediatrician. That's a really good mindset, I think, to approach this with. Mm-hmm. Yeah,
absolutely. There's so many ways to dichotomize people, and this pandemic has definitely, been very polarizing on so many different topics. Yes. And I think vaccines and hesitancy about vaccines is much more than black and white.
Yeah.
Because if it were just black and white, I'm sure someone could have come up with a solution. There are many, many shades of gray and different dynamics that factor into hesitancy.
Well, thank you so much for your time, Dr. Wong. You've answered all of our questions quite comprehensively, and I'm sure that a lot of parents will really find this to be very valuable information. So thank you so much for joining us here today and for helping us as parents to make an informed decision about vaccination for our children.
Well, the pleasure was mine. Again, thank you so much for inviting me to share my experiences and share this information with your viewers. I really appreciate the opportunity.